Macular folds are an uncommon complication after retinal detachment surgery. The main risk factors are superioris bullous retinal detachment, giant retinal tears, and the use of high buckles. When they cross the fovea, they produce a very poor and bad visual prognosis, and they have to be treated. In this case, the patient was operated elsewhere and no scleral buckle was used, but a foveal fold appeared after surgery and was sent for treatment. The OCT clearly shows the foveal location of the fold. The surgery consists of detaching the retina and reattaching it again, opening the foveal fold. Although it's not necessary, I prefer to mark with laser the places we are going to inject fluid to the subretinal space using a 41 gauge cannula connected to the viscous fluid injector. Where to inject? I prefer mid-periphery, far enough from the foveal center where the retina is thinner, to decrease the risk to produce a macular hole. Two injection sites are enough in the majority of cases. We have to remember that we inject in mid-periphery, subretinal fluid tends to detach the more anterior retina. Then to detach the macular area, fluid exchange is performed, collecting the subretinal fluid in the posterior part of the eye. As you can see, we aspirate alternatively in the temporal zone and over optic disc to eliminate to the maximum the fluid on the retina, and at the same time, the air pushes the subretinal fluid towards the posterior pole. With a flexible loop, we move the retina, very gentle, to make these subretinal bubbles to join. This is, in my opinion, the most dangerous maneuver in this surgery. Finesse fully open to avoid excessive pressure on the retina that could make a break. Again, air fluid exchange to confirm that the fovea is detached and mobile. We inject perfluorocarbon liquid reattaching the retina. Although there is no scientific evidence, I always remove the ILM to smooth out the retinal surface and to reduce the risk of epiretinal membrane formation after surgery. As you can see, we stain under perfluorocarbon liquid that produces instantly dyeing, and with gentle retinal massage we help to open the macular fold. The ILM is then removed in a larger area than we perform ILM peeling in mid-sized macular holes. Evidently, the internal limiting membrane could have been removed at the beginning of the procedure, before detaching the retina, but I'd rather to do it in this step, preserving the rigidity of the retina when we detach it. And as you may see, perfluorocarbon liquid has pushed the subretinal fluid to the periphery. A small bite retinotomy is done as peripheral as possible in the supratemporal quadrant to drain as much as possible the subretinal fluid. And at the end, SF6 10% is used to tamponade. This is the aspect of the OCT 2 months after surgery. You can see dumb fill and how there is no fall in the foveal center. 1 year later, visual acuity went to 20/25 with residual monocular metamorphopsya. My top tips: first, recognize the high-risk cases. Try to remove as much as possible the subretinal fluid and use properly the steam roller. And in the fold, clearly affects the foveal center. Don't wait. Thank you for your kind attention.